very good morning, and I welcome you all to this first type of 20 years of Indian ophthalmology celebration session on oculoplasty and tumors. I welcome Dr. Gerald Schulz. Dr. Gerald Schulz is an associate professor at Loma Medical University. He is a director Schulz Clinics, California. He is visiting consultant to Berlin, Tokyo, Bangkok. He is a life member of All India Ophthalmology Society. He is a fellow of American College of Surgeons, AAO, and Royal College of Ophthalmologists. Welcome, Dr. Schulz.
Good morning. I'm glad that you all made it. Too bad others weren't here because they're missing out on a whole series of good talks this morning. This one is going to be very interesting. Yes, this is what it's about. This is going to be systemic inflammatory diseases with devastating pulmonary, renal, and orbital outcomes. You can see that I have no financial interest in this, fortunately, but I do have an emotional one, and you will too at the end of this presentation, because this is what we're dealing with. Okay, this is a 45-year-old Hispanic male. He had periorbital cellulitis, worse on the right side, no light perception for 2 weeks. Can you imagine that he didn't come in for help? No light perception for 2 weeks suddenly, and then the other eye went? Yes, these are the people I deal with. He was vomiting, he had hypertension. Look at the BUN, it's elevated. Kidneys were bad. And of course, you can see what else. No sore throat, no productive, but on our imaging studies, we can see an infiltrate in the lungs. You can see the little yellow arrows. Okay, sputum was negative for TB, but these are the other considerations that we had. So a biopsy was done, a guided CT, and you'll see that the fungal was negative, but this is the biopsy, and we had granulomas in the lungs with lymphocytes, giant cells. Kidneys were biopsied, and we had sclerotic glomerulus, granulomas, and tubules. You can see in the crescentic pattern in the kidneys. So we had partially immune crescentic glomerulonephritis, and of course vasculitis. This is what we're dealing with. So we did serology for collagen diseases, the antibodies to the neutrophil cytoplasmic agents, and the C anchor, or the cytoplasmic anchor antigens. All these were performed because this is what the differential was. Wegener's, look at the anchor there, microscopic polyangiitis, Krauss syndrome, and partially immune necrotizing crescentic glomerulonephritis. Yes, this patient had Wegener's, and we can see the effect on the body. Pulmonary infiltrates, glomerulonephritis, myocarditis. In the orbit, we have scleritis, episcleritis, proptosis, dacryocystitis, and of course central disease, and on the skin. So take a look at the systems that are affected by Wegener's. Dacryo is kind of high, proptosis of the eye pain, and it can affect the retina and the cornea to a lesser extent. So let's take a look at this patient. In the hospital, he had Cytoxan, IV Solumedrol, and he was sent home. He got worse, loss of voice, pain when swallowing, so he was admitted again. Went home, and then he was admitted a third time with all this. And he was put on Vanco, Levaquin, and here's the MRI. you could see for yourself the involvement of the eye. So he was debrided, a lot of purulent drainage, and this time for fungi. He had the sudden loss of vision in the other eye, but in the right eye, the cornea was macerated. Ocular pressures were okay. And this is what we're dealing with. Proptosis with stretching of the optic nerves and retrobulbar edema both eyes. Look at that bulge. So we cultured the nose and we had hyphema. We had right angle branching and we had wider. This is the fungi that we cultured and identified. I like doing this. You'll have to excuse me, but I like going in out of focus on this spore. And here's the breakdown for zygomycetes. This is the gross classification of it, where you have mucor, rhizomucor, rhizopus, and this is the spores that we can see. In mucormycosis, spores, rhizome meaning branching. You can see the branches down there on the right. His condition got worse. Skin became necrotic. I need say no more. And he went into renal failure and expired. Strike one in baseball. 2 weeks later, another case came to my attention. He was semi-comatose, loss of vision in the left eye 5 days earlier. He was diabetic but didn't take his medications, proptosis of the left eye. MRI of the orbits and biopsy. And again, fungus, rhizopus. Remember the branches, you can see it on the left. On the left, the rhizode, it's labeled. Rhizode versus the sporogium without the branches. And here's the sporachia. Died 2 days later. Strike two. So let's go into this. Orbital cellulitis can go rapidly, especially in an immunocompromised patient. Usually it starts in the nose. We culture the eye and the nose. Follow them carefully. Get an ENT consult. Antibiotics, you should have antifungals and antivirals as appropriate. What else did we learn? Very simple. Don't call me for consultation. We don't want strike three. Thank you. Any questions on
Thank you,
this?
Dr. Schulz. Chairman, sir, do you have questions? Yes, please.
Yes, sir.
The cause of death here for
The cause of it?
Yeah.
It was immunocompromised. We had a lot of fungus in there. It was fungus infiltration, but it was basically the immunocompromised condition of the patient causing these Wegners. And when we did the cultures, the fungus is what the two together. Because with the immunocompromised state, the fungi proliferated rapidly.
Yeah, I've seen a couple of few Wagners, and they're usually not so bad. They do kind of survive the disease as well. They were not HIV or anything like that, right? The patients.
Well, that's why I said don't call me in on consultation. We'll call you in instead.
Thank you, Dr. Schulz. Now I invite Dr. Othman. Dr. Othman is FRCS, Fellow Ophthalmic Oncology Center, Wills Eye Hospital. Now he is Professor of Ophthalmology, Kesar Eleni University, Cairo.
Can you put
He's a
the,
Senior Consultant and Founder Director of Oncology, Ocular Oncology Services. World Eye Hospital, Giza, Egypt. Welcome, sir.
So good morning, everybody. Very impressed by the Indian Ophthalmological Society, the All India, and it's been a pleasure to be here. So in this next few minutes, I will share the advances that happened in our Middle East area and Egypt regarding the management of the tumors over the last 20 years. So we'll be focusing on the 214 million population in the Middle East and Gulf countries and North Africa. And I think this is less than 20% of the Indian population, I guess, but still it is significant. Historically, Asia would have the highest load of patients coming with retinoblastoma, but Africa would have the highest mortality of those patients as well. But this is, I think, is history because of due to the admission of the advances in management of those cases. So I will start the experience by what happened before the year 2000. The management of retinoblastoma was primarily by the oncologists. When we were residents, we could see a white mass, a white reflex, a white mass. We didn't identify the types of masses, and we just sent it to the National Cancer Institute to be taken care of. We only had a little role in active management. So cases usually presented in advanced stage with a fixed dilated pupil, neovascular glaucoma, heterochromia, and hyphema. And also they had pseudo-inflammatory presentation like pseudohypopion and orbital cellulitis like picture due to intraocular tumor necrosis. Few of those were unluckily operated due to the wrong diagnosis, and this led to spread of the tumor outside. As you could see, it happened here from glaucoma surgery site in those poor kids. Proptosis was eventually the sad end story of the cases with orbital tumor because mainly due to cultural non-acceptance of enucleation that was considered mutilating for the kids, especially young girls. So families might prefer having the natural course of the disease running instead of taking the eye out. The diffuse infiltrating pattern was posing a problem because of the scarcity and the delay in diagnosis and erroneous management. This child was an 11-year-old child with multiple surgeries, detachment surgery, glaucoma surgery, and the surgeon, interestingly enough, took the iridotomy and biopsied it. It came out as round blue cell tumor. He didn't believe it. He went for a second biopsy and then came out as retinoblastoma. And definitely this affected survival. Tumor spread was into the anterior chamber, to the optic nerve, and even to the brain through the delay in presentation and a delay in management. We were performing enucleation at the time. Nobody emphasized the stress of a long optic nerve stump. The use of biointegrated implant was kind of skeptical because we were afraid of what we couldn't see. You know, the tumor was intraocular, but there was also the speculation that it might be getting back or having orbital recurrences. We didn't know how to properly close, we were not taught how to properly close the posterior tenon, the anterior tenon, and the conjunctiva. And also the pathological and genetic assessment of the enucleated tissue was not a state of the art at the time. Due to the mishaps, this child had post-enucleation lymph node recurrences that was followed by, and all enucleations were followed by external beam radiotherapy, irrespective of the pathology report. This was done by whole eye technique, but for the radiation therapist, they always prefer the lateral beam sparing technique because of they didn't want the patient to have cataract. This was proven to be correct if we could actively manage the area in the very far periphery of the retina towards the aura and or the anterior segment, but this was not within our field of expertise. So we had many issues regarding the orbital hypoplasia. because of the non-use of the orbital implant and the radiation of all patients at the time, the immediate complication as radiation dermatitis, and we saw also the late complications of sarcomas within the radiated field and even outside the radiated field. From the 90s, the mid-90s, the chemotherapy was not associated with consolidation therapy, so this is where the patient took multiple cycles of chemotherapy with decent regression of the tumor and then regrowth of the tumor in a later stage. Enucleation was advised, the patient refused, and they came up with extraocular extension and a bad eye disease in the other eye. Since 2000 on, we took over in the area in Saudi Arabia, the King Khalid Eye Hospital with Dr. Saleh Al-Masfar and his team. They saw around 1,300 eyes since they started in the 2000 era, and also in Jordan 2003. This was the time that at the National Eye Institute in Egypt, we had also the oncology center. Jordan took care of 430 patients over the last 15 years with extremely decent results in early presentation, cases stage A, B, C, and even D. In Egypt, we had two main centers, the National Eye Center and the private Eye World Hospital. We don't have any data about the Children's Cancer Hospital. We do now updated the genetic counseling. We use all treatment modalities. The plaques are available even for treatment of resistant or recurrent cases. And we have the team of trained personnel, dedicated public and private hospital. The diagnostic RedCam is there since 2003. All the therapeutic lines are there, and we have also the local, national, regional, and international collaboration. So we managed around 444 eyes with more than 5 years of follow-up now. Many of those were bilateral cases, and we use all modality of treatment. We still enucleate advanced disease, less advanced disease from A to D, whether unilateral and bilateral RB. We use 2-agent chemotherapy, not 3-agent, for 6 cycles, and the combination of ocular salvage therapy, usually starting from the 2nd cycle, and we delay any decision for enucleation if we mean at actively managing bilateral disease with an intent to treat. These are some of the results of the chemothermotherapy combination. The right eye here, the nerve wasn't seen, total detachment, multiple seeds, retinal, subretinal seeds, and after treatment, this was ended up by being the better seeing eye. The left and the right eye of a baby that grew out through his disease, and we do have similar results on for treatment of the 444 eyes with a decent follow-up period. So for group D, the survival estimate on the mean was a mean of 40% early on, and then we found significant factors in relation to time of event if there was a delay in diagnosis and non-infratemporal lesion location, and the older age than 2 years and unilaterality did affect the results. We could save about 25.3% of unilateral disease, and we concluded that the presentation of retinoblastoma in Egypt tends to be advanced, and the ocular salvage rate with chemofocal therapy using 2-agent chemotherapy is definitely improving. This is the Kaplan-Meier survival at 5 years. We reached 95%. We don't see those advanced cases anymore. Can I take 1 minute? We also, the plaques were very useful in saving the eyes as primary treatment or secondary treatment modality following chemotherapy, laser, or cryo. This is a 2 weeks old child with familial retinoblastoma. Following the 6 cycles of chemothermotherapy, he had a recurrence that was eventually plaqued, and the patient survived over the years. This is the first plaque case for resistant aura seeds that disappeared with the postage stamp plaques. Another case that unilateral disease that was plaqued only with saving the fovea and the macula and the optic nerve on a very long-term basis. We used carboplatin also to give the intra-ophthalmic artery melphalan. The experience wasn't that great because stage E disease, we had recurrences in 5 of the 6 group of the 6 of group E, 2 of the 8 of group D, and 2 out of 5 of group E had prior treatment. We had 2 patients with ophthalmic artery occlusion, as you could see here, and the overall tumor control rate for these 15 cases was only in 8 eyes. This is an ophthalmic artery occlusion that showed early with the experience due probably to damage of the ostium of the ophthalmic artery. This is the second case. Unfortunately, this poor child, we could save the eye, but the vision was lost due to ophthalmic artery occlusion. So we consider intra-ophthalmic artery melphalan as a focal method of delivery of chemotherapy that necessitates adjuvant therapy for further management. The experience of King Khalid in Saudi Arabia was similar, and they could not save any of the eyes that were treated abroad with ophthalmic artery injection. It has its disadvantages and implicated cost. We receive fellows from all over the world to train in ophthalmic oncology. We did some publication, and we also hosted meetings where Dr. Honover honored us by his presence last November, and we still keep pushing towards the bringing more attention to such unconventional subspecialty. Thank you very much.
Thank you, sir, and I compliment you for venturing into this field where these eyes and lives needs to be saved. Thank you once again, Chairman, sir. Since no other presenter is there, so with the permission of Chairman, I conclude this session. Thank you very much. Thank you.